Breast augmentation or breast enhancement surgery is the most common procedure that we as plastic surgeons do across the country on females. It's a procedure that really has become in vogue now across the world, as you see cosmetic surgery and plastic surgery extending far beyond the boundaries of here in the United States. We do a number of plastic surgery procedures, but this one is one that really can change a person's lives. I've literally had patients come in and say, I've felt inadequate all my life because of my breast size. And a lot of it has to do with what we see in the media. I mean, we're drilled into our head, you have to have this look and this size and this shape. And because of that, we see an explosion of cosmetic plastic surgery procedures to the breast throughout the years. Cosmetic surgery of the breast usually entails placing an implant. An implant is a silicone type of structure that can either be saline-filled or gel-filled. And we'll talk about that in a second. Now, basically, there are two approaches to doing augmentation mammoplasty. One is on top of the muscle, what we call prepectoral placement. Generally speaking, most plastic surgeons don't do that type of placement unless there's a special circumstance. The downside of prepectoral placement is the fact that because it's on top of the muscle, there's less coverage from the pectoralis. There's less coverage around the muscle, around the implant to be able to see imperfections, rippling in the implant, defects in the implant, thin skin on top of that. And the main downside to it is the fact that on top of the muscle, up to 30% of these implants may get hard in what we call capsular contracture. Well, what is capsular contracture? You've heard about it if you've read anything on plastic surgery of the breast. Capsular contracture refers to the fact that every time an implant, whether it's a knee implant, a chin implant, a hip implant, is placed in the body doesn't know what it is. It says, hey, you weren't here yesterday. I don't know what you are, but I'm going to encircle you and put a capsule around you because I'm going to protect the rest of the body. And most of the time, that capsule is inert. It just kind of surrounds that implant. But in some women, there is a cell called the myofibroblast, which is half muscle cell and half collagen, half scar cell. And that muscle portion is activated and squeezes. So all those horror stories you see on Oprah and Jenny Jones and all these shows on TV of these breasts look hard, they look distorted, they don't look real, that's capsular contracture. Now, we as plastic surgeons don't have the exact etiology to what causes capsular contracture. There have been a lot of postulates. Some people think it may be a low-grade infection, but we're never able to culture anything out of that. Some people think that it may be an immune response, but yet some people only get it in one breast. We do know, though, however, on top of the muscle in a prepectoral placement, 30% of women will get some form of capsular contracture. And that can be graded in what we call a Baker scale from 1 to 4. 1 being just a little bit firm that because I touch enough breast, I can be able to tell, to being rock hard, which is a grade 4 that you can see across the street because it looks so abnormal. The reason then that we go underneath the muscle or subpectoral is because we decrease that risk from 30% to 10% or less. So that is a main worry of plastic surgeons of getting capsular contractures postoperatively. Now, what do you do if you get a capsular contracture after surgery? What do you do? Well, you can do what we call closed capsulotomy. And literally, when I was a resident in Los Angeles, the implants were placed a lot of the times on top of the muscle. We would actually go into the surgeon's office and actually grab the implant and squeeze the breast to try to rupture the capsule around it. But most likely, the best way to do it is what we call open capsulotomy, where you take the implant out for a second, and the capsule actually looks like the dome. It looks like a circular dome. We actually make tiny incisions in that dome to release the tension on it and then replace the implant. Now, there are other methods you can do. We've now found a chemical that patients can take, that patients literally who have taken for asthma for years called accolate. Accolate is a medication that patients have taken for asthma. And those patients who had implants and had capsular contracture came to their doctors and said, hey, you know what? I took this accolate and my breast is soft again. So we now know that about 15 to 25% of patients will respond to this medication because the same type of cell that causes capsular contracture, that myofibroblast, causes constriction of the airways in asthma that causes somebody not to be able to breathe. If that doesn't work, then open capsulotomy is the only answer to that. Now, patients will ask me, okay, doc, how can I put these in? What are the different approaches to be able to place that implant underneath my muscle? Well, you can go underneath the armpit, which is called a transaxillary approach. The upside to that, it normally hides the incision very well, but I have seen patients who have gotten what we call hypertrophic scars, raised scars, red scars that look angry underneath there. If you get a bleeder from that, trying to create that pocket because you're really far away from where you want the bottom of that implant to be, you can get some bleeding tendencies, and you can't really see it through that. The other downside to that is if you do get a contracture, it's very difficult to release it through the armpit. You can do a periorelar approach, which is around the nipple. Now, that really hides the incision very well. The downside to that is in some women, you may get a decrease in sensitivity to the nipple. The most common approach across the country is what we call an inframammary approach, underneath the fold of the breast, where an incision is made with maybe a couple of centimeters to an inch in size. We dissect underneath the pectoralis muscle, creating a pocket, and then place the implant in, and then inflate it with a little tube to be able to the size that we want. Now, let's look at some of the different types of implants. We have what we call saline implants. Saline implants are literally what they talk about. We fill them up with saline solution, with water, to be able to extend to the size we want. The nice thing about saline implants are they have about a 50 cc overfill. So if you're using a 300 cc or a 325, you can go to 350 to 375. And that is important because if somebody's breast is a little bigger on one side than the other, you can make up for that discrepancy and make the size the same. We have smooth-coated implants. Smooth-coated implants have less of a rupture rate than the rough-coated implants. Rough-coated or textured implants have a little higher rupture rate, but many surgeons will use those because there are some studies that show that it decreases the risk of contracture more than the smooth-coated ones. We're now allowed to use what we call silicone implants, and we've used those for years as plastic surgeons, and silicone implants are a softer implant. If you put a saline and a silicone, you'd say, you know what, doc, this one's a little softer. But when you have two saline and there's nothing to compare them to, they feel like normal breasts. The downside with silicone implant is it needs a little bigger incision. You don't fill those with anything. They're already pre-filled, so it's like stuffing a baby back in. It has to be a little bigger incision to get that implant in. And the other downside is if it does rupture, you may get an inflammatory response around that implant, which I've actually seen actual calcification around that. Breast augmentation is one of the most safest surgeries that we've seen. The complications are very few. Bleeding, infection, which is very, very rare. Rupture of the implant is roughly about 1 to 2% per year. And generally speaking, the manufacturer gives you a 10-year warranty and gives you free implants for life on those type of replacements of those implants. The other downsides that we've talked about are contracture and asymmetry, and occasionally a surgeon may have to go back in to reconstruct the pocket if you have a contracture at that position. Now, what about sizes? Well, in Pittsburgh and the area where we practice, we're a little bit more conservative than some areas. Having been in Los Angeles, usually patients go with a little bigger implants in those type of cities. But generally speaking, most women want to be a large B or a C or a D cup, which we're used to seeing at those sizes. And a rough guide is about 180 to 200 cc's per cup size. So if you're an A and want to go to a C, somewhere around 360 to 400 cc's. If you're an A and want to go to a B, somewhere around 180 to 200 cc's. And that is generally textured and patterned towards the shape of the person. If they have a narrow chest wall, if they have a wider chest wall, there are different types of round implants or high-profile implants to be able to fit those. Now, after surgery, typically what we do is give patients muscle relaxants because women have described it to me as a subpectoral placement as, you know what, doc, it feels like when my milk came in when I had a baby, that crampy-like feeling. So we give them a muscle relaxant, we give them pain medications, and we give them antibiotics post-operatively. Generally speaking, you will either have an ACE wrap or a little garment on you after surgery that supports that breast, and we ask you to wear that for a couple of weeks after surgery, and then go, braless as much as possible to allow the implants, which will ride high, and believe me, you'll wake up and feel like Arnold Schwarzenegger because the muscle contracts and pushes the implant here for 2 to 3 weeks or longer until the implant drops into position. Breast augmentation surgery is something that I've seen in my practice has really changed people's lives. It's made them feel better about themselves. To their husbands, to their boyfriends, they felt sexier. They felt more alive. They felt more like a woman. And in other cases, women have come in and said, you know what? I have to get 2 different sizes of bathing suits. My top is so small and my bottom is so big. Breast augmentation surgery is certainly the most common procedure in this country and will continue to be because it really does help self-esteem. And that's what we're talking about in plastic surgery.